not to be confused with Budd-Chiari syndrome. Chiari malformation. Chiari malformations, CMS, are structural defects in the cerebellum. They consist of a downward displacement of the cerebellar tonsils through the foramen magnum, the opening at the base of the skull, sometimes causing non-communicating hydrocephalus as a result of obstruction of cerebrospinal fluid, CSF, outflow. The cerebrospinal fluid outflow is caused by phase difference in outflow and influx of blood in the vasculature of the brain. The malformation is named for Austrian pathologist Hans Chiari. A type 2 CM is also known as an Arnold-Chiari malformation in honor of Chiari and German pathologist Julius Arnold. CMS can cause headaches, difficulty swallowing, sometimes accompanied by gagging, choking, and vomiting, dizziness, nausea, neck pain, unsteady gait, problems with balance, poor hand coordination, fine motor skills, numbness and tingling of the hands and feet, and speech problems, such as hoarseness. Less often, people with Chiari malformation may experience ringing or buzzing in the ears, tinnitus, weakness, slow heart rhythm, or fast heart rhythm, curvature of the spine, scoliosis, related to spinal cord impairment, abnormal breathing, such as central sleep apnea, characterized by periods of breathing cessation during sleep, and, in severe cases, paralysis. They may also experience difficulty focusing, concentrating, and thinking, as well as difficulty coping with what most consider and experience as normal, everyday life, fatigue, and muscle. Signs and symptoms. Headaches aggravated by Valsalva maneuvers, such as yawning, laughing, crying, coughing, sneezing, or straining, bending over, or getting up suddenly. Tinnitus, ringing in the ears. Lermite's sign, electrical sensation that runs down the back and into the limbs. Vertigo, dizziness. Nausea. Nystagmus, irregular eye movements, typically, so-called downbeat nystagmus. Facial pain. Muscle weakness. Impaired gag reflex. Dysphagia, difficulty swallowing. Restless leg syndrome. Sleep apnea. Sleep disorders. Impaired coordination. Severe cases may develop all the symptoms and signs of a bulbar palsy. Paralysis due to pressure at the cervicomedullary junction may progress in a so-called clockwise fashion, affecting the right arm, then the right leg, then the left leg, and finally the left arm, or the opposite way around. Papilledema on fundoscopic exam due to increased intracranial pressure. Pupillary dilation. Dysautonomia, tachycardia, rapid heart, syncope, fainting, polydipsia, extreme thirst, chronic fatigue. The blockage of cerebrospinal fluid, CSF, flow may also cause a syrinx to form, eventually leading to Syringomyelia. Central cord symptoms such as hand weakness, dissociated sensory loss, and, in severe cases, paralysis may occur. Syringomyelia. Main article, Syringomyelia. Syringomyelia is a chronic progressive degenerative disorder characterized by a fluid-filled cyst located in the spinal cord. Its symptoms include pain, weakness, numbness, and stiffness in the back, shoulders, arms or legs. Other symptoms include headaches, the inability to feel changes in the temperature, sweating, sexual dysfunction, and loss of bowel and bladder control. It is usually seen in the cervical region but can extend into the medulla oblongata and pons, or it can reach downward into the thoracic or lumbar segments. Syringomyelia is often associated with Chiari malformation type I and is commonly seen between the C4 and C6 levels. The exact development of Syringomyelia is unknown, but many theories suggest that the herniated tonsils in Chiari malformation type I form a plug which does not allow an outlet of CSF from the brain to the spinal canal. Syringomyelia is present in 25% of patients with Chiari malformation. Pathophysiology. The most widely accepted pathophysiological mechanism by which Chiari type I malformations occur is by a reduction or lack of development of the posterior fossa as a result of congenital or acquired disorders. Congenital causes include hydrocephalus, craniosynostosis, especially of the lambdoid suture, hyperostosis, such as craniommetaphyseal dysplasia, osteopetrosis, erythroid hyperplasia, X-linked vitamin D-resistant rickets, and neurofibromatosis. Type I acquired disorders include space-occupying lesions due to one of several potential causes ranging from brain tumors to hematomas. Head trauma may cause cerebellar tonsillar ectopia, possibly because of dural strain. Additionally, ectopia may be present but asymptomatic until whiplash causes it to become symptomatic. Posterior fossa hypoplasia causes reduced cerebral and spinal compliance. Diagnosis. Diagnosis is made through a combination of patient history, neurological examination, and medical imaging. Magnetic resonance imaging, MRI, is considered the best imaging modality for Chiari malformation since it visualizes neural tissues such as the cerebellar tonsils and spinal cord as well as bone and other soft tissues. CT and CT myelography are other options and were used prior to the advent of MRI, but they characterize syringomyelia and other neural abnormalities less well. By convention, the cerebellar tonsil position is measured relative to the Bayesian line, using sagittal T1 MRI images or sagittal CT images. The selected cutoff distance for abnormal tonsil position is somewhat arbitrary since not everyone will be symptomatic at a certain amount of tonsil displacement, and the probability of symptoms and syrinx increases with greater displacement. However, greater than 5 mm is the most frequently cited cutoff number, though some consider 3-5 mm to be borderline, and symptoms and syrinx may occur above that. One study showed little difference in cerebellar tonsil position between standard recumbent MRI and upright MRI for patients without a history of whiplash injury. Neuroradiological investigation is used to first rule out any intracranial condition that could be responsible for tonsillar herniation. Neuroradiological diagnostics evaluate the severity of crowding of the neural structures within the posterior cranial fossa and their impact on the foramen magnum. Chiari 1.5 is a term used when both brainstem and tonsillar herniation through the foramen magnum are present. The diagnosis of a Chiari 2 malformation can be made prenatally through ultrasound. Classification. In the late 19th century, Austrian pathologist Hans Chiari described seemingly related anomalies of the hindbrain, the so-called Chiari malformations I, II and III. Later, other investigators added a fourth, Chiari 4, malformation. The scale of severity is rated I4, with 4 being the most severe. Types 3 and 4 are very rare. Other conditions sometimes associated with Chiari malformation include hydrocephalus, syringomyelia, spinal curvature, tethered spinal cord syndrome, and connective tissue disorders such as Ehlers-Danlos syndrome and Marfan syndrome. Chiari malformation is the most frequently used term for this set of conditions. The use of the term Arnold-Chiari malformation has fallen somewhat out of favor over time, although it is used to refer to the type 2 malformation. Current sources use Chiari malformation to describe 4 specific types of the condition, reserving the term Arnold-Chiari for type 2 only. Some sources still use Arnold-Chiari for all 4 types. Chiari malformation or Arnold-Chiari malformation should not be confused with Budd-Chiari syndrome, a hepatic condition also named for Hans Chiari. In pseudo-Chiari malformation, leaking of CSF may cause displacement of the cerebellar tonsils and similar symptoms sufficient to be mistaken for a Chiari I malformation. Treatment. While there is no current cure, the treatments for Chiari malformation are surgery and management of symptoms, based on the occurrence of clinical symptoms rather than the radiological findings. The presence of a syrinx is known to give specific signs and symptoms that vary from dysesthetic sensations to oligothermal dissociation to spasticity and paresis. These are important indications that decompressive surgery is needed for patients with Chiari malformation type 2. Type 2 patients have severe brain stem damage and rapidly diminishing neurological response. Decompressive surgery involves removing the lamina of the first and sometimes the second or third cervical vertebrae and part of the occipital bone of the skull to relieve pressure. The flow of spinal fluid may be augmented by a shunt. Since this surgery usually involves the opening of the dura mater and the expansion of the space beneath, a dural graft is usually applied to cover the expanded posterior fossa. A small number of neurological surgeons believe that detethering the spinal cord as an alternate approach relieves the compression of the brain against the skull opening, foramen magnum, obviating the need for decompression surgery and associated trauma. However, this approach is significantly less documented in the medical literature, with reports on only a handful of patients. It should be noted that the alternative spinal surgery is also not without risk. Complications of decompression surgery can arise. They include bleeding, damage to structures in the brain and spinal canal, meningitis, CSF fistulas, occipitocervical instability, and pseudomeningocele. Rare post-operative complications include hydrocephalus and brain stem compression by retroflexion of odontoid. Also, an extended CVD created by a wide opening and big duroplasty can cause a cerebellar slump. This complication needs to be corrected by cranioplasty. In certain cases, irreducible compression of the brainstem occurs from in front, anteriorly or ventral, resulting in a smaller posterior fossa and associated Chiari malformation. In these cases, an anterior decompression is required. The most commonly used approach is to operate through the mouth, transoral, to remove the bone compressing the brainstem, typically the odontoid. This results in decompressing the brainstem and therefore gives more room for the cerebellum, thus decompressing the Chiari malformation. Arnold Menzies, MD, is the neurosurgeon who pioneered this approach in the 1970s at the University of Iowa. Between 1984 and 2008, the MR imaging era, 298 patients with irreducible ventral compression of the brainstem and Chiari type 1 malformation underwent a transoral approach for ventral cervicomedullary decompression at the University of Iowa. The results have been excellent, resulting in improved brainstem function and resolution of the Chiari malformation in the majority of patients. Epidemiology. The prevalence of congenital Chiari malformation, defined as tonsillar herniations of 3 to 5 mm or greater, was previously believed to be in the range of 1 per 1,000 births, but is likely much higher. Women are 3 times more likely than men to have a congenital Chiari malformation. Type 2 malformations are more prevalent in people of Celtic descent. A study using upright MRI found cerebellar tonsillar ectopia in 23% of adults with headache from motor vehicle accident head trauma. Upright MRI was more than twice as sensitive as standard MRI, likely because gravity affects cerebellar position. Cases of congenital Chiari malformation may be explained by evolutionary and genetic factors. Typically, an infant's brain weighs around 400 grams at birth and triples to 1,100 to 1,400 grams by age 11. At the same time, the cranium triples in volume from 500 cubic centimeters to 1,500 cubic centimeters to accommodate the growing brain. During human evolution, the skull underwent numerous changes to accommodate the growing brain. The evolutionary changes included increased size and shape of the skull, decreased basal angle and basicranial length. These modifications resulted in significant reduction of the size of the posterior fossa in modern humans. In normal adults, the posterior fossa comprises 27% of the total intracranial space, while in adults with Chiari type I, it is only 21%. If a modern brain is paired with a less modern skull, the posterior fossa may be too small, so that the only place where the cerebellum can expand is the foramen magnum, leading to development of GRE type IH Neanderthalensis head platycephalic, flattened, skull. Some cases of GRE are associated with platybasia, flattening of the skull base. History. The history of GRE malformation is described below and categorized by the year. 1883, Cleland was the first to describe GRE2 or Arnold-Chiari malformation on his report of a child with spina bifida, hydrocephalus, and anatomical alterations of the cerebellum and brainstem. 1891, Hans Chiari, a Viennese pathologist, described the case of a 17-year-old woman with elongation of the tonsils into cone-shaped projections which accompany the medulla and are crammed into the spinal canal. 1907, Schwalbe and Griedig, pupils of German pathologist Julius Arnold, described 4 cases of meningomyelocele and alterations in the brainstem and cerebellum, and gave the name Arnold-Chiari to these malformations. 1932, Van Hoeninge-Grafdijk was the first to report the surgical treatment of GRE malformations. All patients died from surgery or postoperative complications. 1935, Russell and Donald suggested that decompression of the spinal cord at the foramen magnum might facilitate the CSF circulation. 1940, Gustafsson and Oldberg diagnosed GRE malformation with Syringomyelia. 1974, Bloch et al. Described the tonsil's position to be classified between 7 mm and 8 mm below cerebellum. 1985, Abolas used MRI for discovery of extension. Society and culture. The condition was brought to the mainstream on the series CSI, Crime Scene Investigation in the 10th season episode Internal Combustion on February 4, 2010. GRE malformation was briefly mentioned on the medical drama House MD in the 5th season episode House Divided, and it was the focus of the 6th season episode The Choice. It is also the focus of Private Practice Season 4 Episode 4, where a pregnant woman is diagnosed with it. It was also mentioned in the medical drama A Gifted Man, in the 1st season episode In Case of Separation Anxiety. GRE malformation has also been featured in non-fiction TV shows. Season 5, Episode 2 of Extreme Makeover, Home Edition features a family where both mom and daughters have GRE malformation. On the Discovery Health Channel series Mystery Diagnosis, a young girl is diagnosed with GRE malformation and Ehlers-Danlos syndrome in the 1st season episode Blood and Fire. Notable people: Roseanne Cash, U.S. singer-songwriter, daughter of Johnny Cash. Julia Kluge, U.S. luge competitor for Team USA in 2010 Vancouver Winter Olympics. Joanna David, British television and stage actress. J.B. Holmes, U.S. professional golfer. Marissa Irwin, U.S. fashion model with GRE secondary to Ehlers-Danlos syndrome. Bobby Jones, U.S. World Golf Hall of Fame golfer and founder of the Augusta National Golf Club. Leah Shapiro, U.S. drummer for the band Black Rebel Motorcycle Club. Michelle Stilwell, Canadian wheelchair racer and politician. Alyssa Seeley, gold medalist at the 2016 Summer Paralympics in the para triathlon.
Please subscribe and thanks for watching.